With this, we move on to the next scientific session, and the topic is Vonoprazan, a new acid suppressant, current status. To speak on this particular topic, I would like to invite Dr. Srikant Mohta, who is a gastroenterologist and interventional endoscopist with an overall experience of 9 years, and he has published several research papers in national and international journals. He is attached to Narayana and renowned for his expertise in treating complex gastrointestinal disorders. I welcome you, sir. To chair this particular session, I would like to invite Dr. Dilip Todi, highly skilled and experienced medical gastroenterologist with more than 37 years of experience. He is attached to Narayana Super Speciality Hospital and the founder member and member of Scientific Affairs of Howrah Town Diabetes Study Society. Along with him, I would like to invite Dr. Somnath Mukhopadhyay, senior consultant gastroenterologist with overall 32 years of experience attached to CMRI. I welcome chairpersons and I welcome speakers.
At the outset, I would like to thank the organizing committee to allow me to speak on this new kid on the block and something that has been taking the pharma companies and us by storm. How much of it is just to be taken into our practice and how much of it is just sham or how much of it is really just marketing, we need to sort out. And I hope to give some clarity over this topic over the next 15 to 20 minutes. So the outline of my presentation will be, do we need a change? What are the unmet needs that we have with the current available therapy in acid suppression? The introduction to this new class of potassium channel blockers and Vonoprazan being the key stakeholder in this group, the scientific evidence that is available for this class, because that is where we will be able to decide whether to take it into our stride or not. What are the limited guideline recommendations regarding this based on the available scientific evidence, and then we'll summarize and probably discuss a little. So acid-related diseases are a whole spectrum of diseases, including the common gastroesophageal reflux disease, which can be erosive or non-erosive. I have written erosive esophagitis separately because a major part of our discussion will be around erosive esophagitis, Barrett's esophagus, peptic ulcer disease, the rare diseases of Zollinger-Ellison syndrome, and the commonly seen H. pylori infection. So the evolution of acid suppression therapy, we have been having lifestyle recommendation and liquid antacids and tablet form of antacids since more than 100 years now. Then came in the prokinetics and the H2 receptor antagonists. These took everything by storm and led to dramatic improvements in the ulcer healing, and the morbidity of ulcers reduced, and ulcer was no more a dreaded disease. When PPI came, it almost became non-existent that people used to die of ulcers. It became very rare. And PPI was so good that for the next 30 to 40 years, there was hardly any innovation in this field. And we all routinely use it. Every second patient of ours, be it gastroenterology or be it general practice, gets PPI. Then what was the need for a change, and why did the Japanese make this new molecule called PCABs, which got recent approval? So PPIs had some unmet needs, even though they are very good medications, but with all medications we have some problems. So they act on the proton pumps. So in the stomach there is a proton pump which I will be showing you. They act on the proton pumps which are active. So like all our bodily functions, it is obvious that in the stomach not all proton pumps will be active at a time. So going by that same logic, PPIs cannot block all of them at the same time and therefore cannot give us complete acid resolution. So that is why many of our patients remain resistant to the medication, and the non-acid reflux symptoms, that is the extraesophageal symptoms like chronic cough and dry cough or asthma, these medications don't have a very good response in the extraesophageal manifestations of GERD. It is a slow onset of action. The first 3 to 5 days the PPI takes a steady state. It gradually reaches a steady state level in the body, and then it starts giving its peak action. So the first 3 to 5 days are critical, and the symptom, because the patient does not come for his ulcer, he comes for his abdominal pain. If you don't treat that within the first 5 days, he loses trust in us. Then more frequent dosing is required because, as I said, not all the proton pumps can be blocked, and these PPIs have now got to be enteric coat quoted because they are not stable in the acidic condition. They do not provide a very uniform pH less than 4 because of the fluctuation in the activity of proton pumps. And because this is a conference related to diabetes and medical practitioners are in abundance here, clopidogrel, and the cardiology session has just finished. Clopidogrel is very commonly used in those patients with multiple comorbidities. So my unmet need will not be finished before I say that clopidogrel has a interaction with PPI, and wherein esomeprazole, if it is given with clopidogrel, the clopidogrel does not function properly. So I have spent some time on this slide because the rest of the slides will depend on this. Now coming to quickly, the proton pump which is there in the stomach. This proton pump leads to an exchange in the potassium and the proton pump. Proton and potassium go outwards and inwards. The PPI acts on this irreversibly and blocks this pump. This is the same target is available for the PCAB or Vonoprazan also, but the modality is different because the PPI binds in an ionic manner and PCAB binds in a covalent manner. So Vonoprazan, just giving you a basic idea about Vonoprazan, then we'll be talking about the difference with PPI. It comes in two strengths, 10 milligrams and 20 milligrams. It belongs to this new class called PCABs, and it has recently received approval in most of the countries. US FDA has also approved it, and Indian government has also approved it recently, and it is available in abundance. It is orally active and binds to a particular subunit of the proton pump. It is reversible and dose dependent. However, the studies which I'll show you will show that it is not really dose dependent in actual clinical manifestations. And the most important point is that meal has no effect on the rate of absorption or its activity, which is a very important point in PPI, because if we don't give it half an hour before a meal, or the patient takes it and does not eat for the next 2-3 hours, the PPI effect really goes down. You have to eat after half an hour and it has to be taken before a meal. This thing is not valid for Vonoprazan. How does its mechanism of action differ? So Vonoprazan selectively concentrates near the resting as well as the active proton pumps, while the PPI selectively acts only on the active pumps. So pumps get activated when we eat food. So that is why it is recommended to eat after a PPI, because if you don't eat, no pumps will be active and the PPI will not be effective. Vonoprazan does not carry this problem. The reversible interaction allows, like when the proton pumps are activated, so they stay activated for some time. Once the PPI binds to them, it stays there for 24 hours, and therefore the proton pump does not act. But after the next meal, some new proton pumps may get activated. But in Vonoprazan, these action after the half-life, it gets deactivated, and the new active proton pumps, it can bind to those channels. So therefore, that same PCAB molecule can act on multiple channels over the course of the day. So with almost the similar points which I covered for proton pump, let's see whether they are now still a disadvantage. It binds in a reversible manner. The first dose effect is not there. It does not need a stable half-life, because in PPI, gradually all the proton pumps get blocked over time with 3 to 5 days of use. In Vonoprazan, from day 1, we start to get clinical efficacy. It does not require acid activation. It is rapid, and it is a strong, covalent bond is strong by our chemistry knowledge. So it is a strong acid suppression, like PPIs also. And because of its long half-life, it has shown a more stable pH of less than 4. And because of this more stable and long half-life, it has shown to be having good role in nocturnal acid breakthrough, which is a problem with PPI use, and we often need to give some H2 receptor antagonist at night with those with severe symptoms. And practical point, it can be taken with or without food. This table again summarizes the same thing. I will not go over it in detail again, but this just shows the same points which we have discussed already. So now coming to the scientific evidence, what has been there. First disease, I'll be covering the different acid reflux disease, acid related diseases which I had shown. So in 2023, a major trial showed that erosive esophagitis, the PPIs were compared to Vonoprazan in the healing phase and the maintenance phase. So this compared a standard PPI which was lansoprazole, but mind you, in the maintenance phase they used a lower dose. What were the results? The results showed that when all erosive esophagitis were taken into account, still Vonoprazan showed better statistically significant healing as compared to the PPI at week 2 and at week 8. Although both were showed good efficacy, but Vonoprazan was significantly better. And the difference becomes even more marked when we see severe esophagitis. Severe esophagitis, we grade it endoscopically as a Los Angeles staging of C and D, which basically means there are very large ulcers in the esophagus, which can lead to hematemesis and are often seen with hiatus hernia. So in these class of patients, vonoprazan did remarkably better. Again, similar results were seen in the maintenance phase. Those were the induction phase results. Similar results were seen in the maintenance phase, wherein the maintenance was also better with the vonoprazan arm. Then what about nocturnal acid breakthrough? Nocturnal acid breakthrough, this trial compared the patients whether the first dose effect and the nocturnal acid effect was better on the first day with vonoprazan as compared to PPI. So they saw that both the daytime heartburn as well as the nighttime heartburn was significantly better improved on day 1. This trial was not to be seen at a later date. This was basically for the first week, and which found that even at first day as well as days 2 to 7, vonoprazan was better as compared to the proton pump inhibitors. Then coming to peptic ulcer disease, over the period of 8 weeks, the PPI and vonoprazan fared equally here. It was non-inferior to the standard PPI, which is a very good thing, because PPI we know that has done remarkable work in the peptic ulcers, and we don't need to worry about it once we give it. So if it is performing equally, that means it is showing really good efficacy. A systematic review based on, again, on nocturnal acid breakthrough, because it's a systematic review, I am including it here. It showed that for nocturnal acid breakthrough, vonoprazan showed very good efficacy as compared to the standard antacid and PPI. This is another landmark trial from this year, where it was shown that non-erosive reflux disease, because most of our patients, if 100 patients of GERD are taken, 65% of our patients are non-erosive reflux disease. So this is the most common entity that we see. So a trial on this group, when it was done, like the first initial 4 weeks, patients got either placebo, 10 mg vonoprazan or 20 mg vonoprazan. But at the second, after the 4 weeks, all patients got vonoprazan at different doses. So they found, if you look at this graph here, they found that in the initial phase, vonoprazan patients fared better initially. You can see that the blue and orange arm, the vonoprazan patients fared better than the placebo, which is the lower arm. And in the later phase, after the 4 weeks, once the vonoprazan was given to all patients, all of them practically reached the same graph, showing that vonoprazan can benefit whenever it is given, but both doses performed relatively same. So 10 milligram and 20 milligram, which I told you initially also, even though pharmacologically it shows a dose dependent effect, clinically how much relevance that carries is doubtful, because both doses showed similar effect. The same study meaning the same disease group, non-erosive reflux disease, a systematic review also showed similar efficacy to PPI, in fact a little better. And the last disease I want to talk about is H. pylori eradication. Again, something we face every day. So H. pylori eradication, we all give clarithromycin, amoxicillin and PPIs for 2 weeks in twice daily dosing. And if they don't respond, we give to the quadruple therapy including bismuth. But vonoprazan, still our eradication rates are dismal because of the antibiotic resistance that we see in our countries. So vonoprazan was tried as a triple therapy with clarithromycin, amoxicillin, and as a dual therapy with amoxicillin. Both triple therapy as well as dual therapy fared better than the PPI based regimens. How much this translates into Indian practice is still questionable, because this is Western data wherein the resistance rates are much lower. But to balance that, the data was also given for clarithromycin and amoxicillin resistant groups. So this may carry relevance for us also, and it again showed that vonoprazan based regimens showed much better efficacy as compared to the standard PPI based regimens. A drug is only accepted if it is safe. So what is the safety profile? It has been shown to have good safety similar to PPI and good palatability and tolerability. The data regarding it, a vision trial, this is the result from 2023 wherein the 3-year data is available, and now the 5-year data from the same group, the vision trial has come in, where they have not found any major adverse events with vonoprazan. However, it would be foolishness to assume that over long term it would not have any side effects, because if PPI has side effects, this is a stronger acid blocker, it will definitely carry those same side effects. But maybe the side effects which are peculiar to PPI, like interstitial nephritis, may or may not be there. Only longer term data will tell us, but it is for sure that major side effects are not there. And we all know that the PPIs also, the side effects that are there are more associations than causative side effects. So it is a relatively safe drug. So now that we have all the evidence in our hand, what are the indications? Again, this is basically showing that all the acid related diseases that we talked about, ulcer disease, H. pylori, again erosive esophagitis, non-erosive esophagitis, it can be used for all those categories, and we have evidence in form of randomized control trials in most of these indications. So this is a summary slide for the dosing. When we have esophagitis, we should use it at 20 milligram once a day for 8 weeks. To maintain the healing of this esophagitis, probably if it is severe esophagitis, then 10 milligram can be given for a longer period of time, and 20 mg twice daily can be used for H. pylori eradication, similar to our PPIs. The special scenarios, because of the multimorbidity that obese patients have and many patients have, in chronic kidney disease, when the creatinine, the GFR is less than 30 ml, the dose should not be used for above 10 milligram. We don't have data for that. Chronic liver disease, which we face regularly, in child A, that is compensated liver disease, we should use 20 milligram, which is the standard dose. But we are all scared of using PPI in decompensated chronic liver disease because of the higher rates of infection. So in decompensated, we should use a stronger, the lower dose which is available. And mind you, there is no data till now for pregnancy and lactation, so it would be better suited to continue to use the proton pump inhibitors. As I told you, based on the evidence, Japan is the country where this drug was initially made, and they have been using it for almost 10 years now. So the guidelines which are latest available from their side, they have shown again that mild reflux esophagitis or severe esophageal reflux disease, they have given strong recommendation for this molecule to be used in all types of acid reflux diseases and acid related diseases, and for H. pylori treatment. To summarize, currently available PPIs represent the mainstay of management. We have been using them for very long, many of you for 20, 30 years, and you know how safe these medications are. However, despite their very good use, there are some unmet needs which we have talked about, like resistance, nocturnal acid breakthrough, and slow onset of action. So in these contexts, this novel agent may be really useful for us. And it has been given approval by our society as well as the Western societies. So it is probably a safe drug with good robust data now available. It has now been introduced in India with multiple pharmacological companies. It is easily available. There is a very good ulcer healing rate of above 90%, and as well as more than 80% healing of eradication of H. pylori from Western countries. It is safe and well tolerated and is a novel alternative for the treatment of acid reflux diseases. However, there is a caveat. We don't have too much Indian data for it, and we all know that Indian GI system is not the same as Western. So we need to take it with a pinch of salt, and probably if you ask me, can it replace PPI, which is the most rampant question currently available? Should we replace our prescriptions with PPI? I am not sure about the incremental gain. Whether we should have an incremental gain with using PCABs as compared to PPI, we are still not sure. But yes, we can use it for those with severe esophagitis, refractory GERD cases who are not responding, and patients who have H. pylori which are not being eradicated by our current protocols. For the rest of the common indications, probably time will tell when more Indian data is available. Thank you for your patient listening. I am more than happy to take questions.
Thank you, Srikant, for an excellent deliberation on Vonoprazan. If I am allowed to kick off the question session, looking at the data of erosive esophagitis, you would also agree that the dose comparison that they have made of 20 with 30 of lansoprazole, that is a little bit skewed and underpowered, really, because most people would use 60 of lansoprazole in that scenario, and in the maintenance as well, they have used 15 of lansoprazole. Yes. Now, realistically, who uses 15? It's a little bit of pharma type positive trial scenario. Number two is, if you looked at the evidence for non-erosive, I think most of the evidence is in favor of using it as on-demand. That therein lies the USP, because you are not having to use it long-term. I use it on-demand and it acts immediately. And as you mentioned, for the H. pylori, we need more Indian data, because with the present therapy with PPIs, the eradication in real terms is about 30% with triple therapy. So I don't see how it is going to be 88%.
Yes, I completely agree with all your statements, sir, because as you said, lansoprazole, we tend to use in severe esophagitis the double dose, which is the 60 milligram. And that's why I still feel that the initial treatment, we should still not switch over to vonoprazan immediately. However, there is, I would still say there is a role for this drug. And especially as you said, on demand, and those who are not responding to PPI, it is worthwhile probably giving them a trial of vonoprazan in current scenario. And the nocturnal acid breakthrough, probably it is a better drug than the H2 receptor antagonist which we use, or the antacids, as it has a mucosal healing property which is unlike the other antacids we use. Yes, sir, that is one, like we had talked about, I forgot to mention, PPI definitely has a contraindication and an interaction, especially esomeprazole, and this is metabolized by the CYP3A4 pathway, while the clopidogrel is CYP2C19. So the interaction is not there, and it is a very good drug to be used in that select population also. And it has been shown, in fact, though there are no randomized control trials, but NSAID induced or aspirin like antiplatelet related gastropathy, it has been shown to be very effective and prevent it. But there is no RCT, so I didn't show it. But there is data now. Sir, in those who bleed, sir, I would still say aspirin. Aspirin.
Any question? Somanida.
Use in pediatrics?
So pediatric dosage is still not confirmed, and there is not much data to recommend. In the special population, there is not, like pregnancy, lactation, I am not aware of any robust data in pediatric population. Probably now that the drug is freely available, there will be more data. Till now, I don't think it is recommended, as of my knowledge.
It is found that in PPI, long-term PPI, there is a rebound after a stoppage of the rebound acid.
This is the same with this drug also, because the mechanism is same, sir. That rebound will be there, and now the Canadian Gastroenterology Society has come up with regimens to taper PPI and how to stop it. Similarly, probably the half dose and probably alternate day dosing will be a good method to taper off this medication, and probably we will be able to taper it off more successfully, because like I said, in PPI there is a steady state that needs to be reached. This is not the same here. So even if you give it alternate day, it will work in the same way. So probably tapering will be easier in this medication. But rebound will be there.
Please.
AKI in PPI is more.
Sir?
Here,
Excuse me.
AKI
Yes, sir.
is in PPI.
Is more.
Please give a chance to the next speaker.
Regarding Dr. Pandey's question, aspirin or clopidogrel in a case with GI bleeding. I think clopidogrel is preferable, because aspirin is certainly more, definitely known to cause more GI bleed. If the patient is on esomeprazole or others, we can switch over to now that ranitidine or famotidine. That will be safer. Clopidogrel, in my opinion, is safer than ecosprin when a patient bleeds.
Sir, a small caveat, like if you ask me upfront, when we are not giving PPI, which will bleed more, I agree with you, aspirin will bleed more. But the protective action of PPI with aspirin is much better than clopidogrel. So if the patient has bled, he will remain on PPI usually. So in those cases, aspirin can be easily used. If we are not giving PPI for some reason, then I agree with you, sir, then clopidogrel is safer.
Does this drug has any role in the two cases, like
Sir?
the Zollinger-Ellison syndrome or functional dyspepsia?
Sir, Zollinger-Ellison syndrome, I think it is a new drug, and that is a rare disease. Probably it will take some time, but since the physiology is hyperacid secretion, it should have a role physiologically. Secondly, sir, about the functional dyspepsia, because functional dyspepsia is more of a motor disturbance and a gastric accommodation reflex disturbance. I don't think it will have much role. It will have almost a similar role as PPI, and that is why probably in some time it is expected that combination with domperidone will also come with this medication, which will be a better combination for functional dyspepsia.
Thank you.
Sir, probably it will be there because the mechanism is same. It should be there. Long term will probably.
What is the
dose? What is the dose of Vonoprazan in the treatment of gastroesophageal reflux disease with Helicobacter pylori?
Sir,
And
20
what is the
milligram.
duration?
20 milligram twice daily for the initial eradication therapy.
Twice daily
Twice daily.
for 10 days.
For 14 days.
For 14 days.
With the two
Simply
antibiotics.
alone or with the
With
some
two
other-
antibiotics, sir. Currently, clarithromycin and amoxicillin.
There is no need of antibiotics here.
No, there is need, sir.
With
Clarithromycin,
this.
amoxicillin, and vonoprazan.
Thank you, Srikant,
Thank
for
you,
an
sir.
excellent deliberation. We will stop here. Thank you very much.
Thank you, Speaker sir. I would request the chairpersons to kindly felicitate Dr. Srikant Mohta. I would like to invite Dr. BP Pandey to kindly felicitate our chairpersons for this session. Thank you, Speaker sir, for such an enriching presentation, and thank you, chairpersons.